Okay, all right, so good afternoon once again. Welcome to this afternoon's echo session. Thank you all for coming through. I can see the numbers are getting bigger and bigger. Hope more will join. But in the interest of time, I think we'll get started. The other people will find us on the way. So thank you all for coming through, for finding time to join us for this important session. I'll be your facilitator for this session. My name is Kenneth Kapolowe. I'll take you through this session. So today we're basically looking at the topic of HIV drug-resistant surveillance in Zambia. So this is an important topic that we need to digest this afternoon. So basically, the background to this session is we know that HIV drug resistance is basically the ability of the virus to mutate and replicate or grow in the presence of antiretroviral drugs. And we all know we know the consequences of drug resistance, and some of which include treatment failure. Others include the transmission of this resistant virus to other patients, and of course, direct and indirect costs, both at individual level as well as at a healthcare level, pertaining to the use of second line and third line agents, which tend to be expensive and also toxic to our patients. Then, so we're looking at the topic of surveillance. So surveillance is one of the strategies that can actually be used that can be employed in order to scale up as well as maintain our clients on ART. And there are different approaches when it comes to surveillance. So I think that's what we're basically going to look at this afternoon. And of note, what we're going to focus on, basically, we're going to look at the rationale and approach to HIV drug resistance in Zambia. Then also going to look at the current status of HIV drug resistance surveillance in Zambia. So to take us through this session is Dr. Seville, consultant infectious disease specialist, who is also HIV National HIV Technical Advisor, Ministry of Health. Dr. Seville, you are very much welcome. Yes, then we also have a panel of experts who are going to help us discuss this topic. And these include Dr. Chitembo, Dr. Henry Piri. I've seen Dr. Chitembo is on the call. I'm not so sure Dr. Henry Piri. We also have someone from the lab, Banji, will join us, as well as Dr. Ranjit Warrior. So I hope those who haven't joined us, I'm sure they will join us in the course of the discussion. Yes, so this is how we're going to proceed this afternoon. So just before we start our session, I just want to remind the network to just kindly log in using the link that has been provided in the chat box. Then we'll have a didactic presentation. Then we'll have a question and answer session, at which point everyone will be allowed, will be given the opportunity to give their comments and questions. So, but in the course of the presentation, if you have any comment or question, you can actually just drop it in the chat box, and we'll pick it up much later. So at this point in time, I just want to welcome Dr. Seville, and he'll probably introduce himself a bit more. Then we can start the presentation. Dr. Seville, you're welcome, and you can get started with the presentation. Thank you very much.
Thank you, Dr. Kenneth. I don't know if you can hear me and if my slides are visible.
Yes, I can see your slides and you are quite audible. I hope everyone in the network can get you as well.
Okay. Yeah, so I'm Seville, program. I was asked to give this presentation. For the sake of bandwidth, we will switch off. usual. Okay. Yeah, so I will take you through HIV drug resistant testing in Zambia. This is really in terms of surveillance, as Dr. Kapolo had introduced the topic. So quickly, this is what we look at, and in terms of outline of my presentation. Yeah, so when you start somebody in treatment, this is from at least pre-DTG data. It's expected that within about 6 weeks, which is 4 months, somebody should really be undetectable. And this is how you expect the virus to viral to decline. In the first week, you expect at least close to a 1 log drop. So a log, as you know, is a factor of 10. So if somebody was a 1 million, at least should be below 100,000. Typically in the DTG era now, with very potent therapies that we're using, we've seen some patients suppress within a week. Yeah, so this data is at the very least. So once you start therapy, you really expect the viral load to drop into suppression. Usually, depending on the asset, what you are using, there will be a detectable limit where you can see it. But even below that, you have some viral activity. Yeah. And sometimes you have a rebound where the virus load begins to go up again. This can happen prior to really getting below the detectable limit, or indeed after you are undetectable, you become detectable again. Now, when somebody is infected with the HIV virus, we know that at the early point, you have these the so-called wild type. It can be shown here, like in green, what you see. So this will be like the drug susceptible quasi species that the drugs can work. Can stop the replication. But because of the high replication rates of virus, there will be some quasi species which will be inherently non-resistant. Dr. Kapolo, are we having the poll questions?
Yes, Dr. Seville, you should.
Well, maybe this is a good time to have the first poll question.
Yeah, okay, thank you. Thank you very much, Dr. Seville, for that preamble. So we go to our first poll question. So the question reads, which of the following is true concerning the causes of HIV drug resistance? So the first option is pre-existing mutant virions. Option B is prior use of antiretroviral drugs. C, inconsistent taking of antiretroviral drugs. D is wrong combination of antiretroviral drugs. And E is all of the above. So let's all give it a go. We'll give it a few seconds before we close the poll. So basically the question is asking about causes of HIV drug resistance. So there could be multiple answers. Yes, so okay, so those are the responses. Okay, I think at this point in time, we're going to end the poll. So the majority, 91% have gone for the last option, which is E, all of the above. Yeah, thank you. I guess we're going to look at the answers much later, or Dr. Seville, would you want to comment on the responses at this moment?
Thank you, Dr. Kapolaway. Yeah, so if you can see the answers, and it's interesting that people have said all of the above. Yeah, so like the slide is showing on the background, you have these quasi species at the beginning of ART, and because the virus replicates a lot, so there will be mutants. Some of the mutants, by the way of chance, will be resistant to some of the drugs, especially those combinations that have got a lower genetic barrier. So that's one of the reasons that you'd want to have a combination of drugs as opposed to one class of drugs. Now, we know that it doesn't matter how potent the drug is, one class of drugs, a DTG only, darunava only, which are very potent drugs, might not be good enough. Yeah, so, yeah, so again, prior use does happen, and inconsistent taking, we know that. So the answer is really all of the above. I don't know if I can proceed, Dr. Kapolo, now.
Yes, you can go ahead,
Sure. Yeah. So you can see that there is a green population, and there will be this brown or purple population of the virus that will be inherently, before you start the treatment, which will be resistance to the drug. And depending on what sort of combinations you have, you will clear off the resistance one. And over time, you have this subpopulation developing resistance or growing because they're multiplying because the treatment cannot clear them. So this is really what happens in a simplified form. And this is really the same case you find in TB and most of those drugs that you would want to use combination therapy. So this is really why there are those subspecies that are you know, inherently resistant, and why they do develop occurs, because really the half-life of viral replication is very fast. Over 30 minutes, you have a replication, and there's this, you know, there's that Bax gene, if you remember, which should pick, you know, the mutants. So the so-called, you know, proofreading of the mutation, it's not there. It doesn't happen in this virus. So the chances of having mutations is really, really high, and that's the reason. So where there's a lot of replication, when the viral loads are high, chances of having mutations tends to be very high, and sometimes these mutations will really cause resistance. Yeah, will be the so-called drug resistance mutation, and this is really what you expect the frequency of a mutation to occur. So it's a product of also high viral loads, and this is crucial because we go through facilities and we find somebody on ESC for 2 years, 3 years, and so on. So this is really to illustrate that you don't really want high viral loads, yeah, because you can see that the days before mutations arise tends to be shorter if the viral load is high. Please, let's switch the patients to potent drugs. Once we see at the end of, you know, your ESC, you find the viral load is very high, you switch the patients. The longer the patient stays with a high viral load on treatment, even without drug pressure, the higher the chances of them having these mutations, which sometimes can be the so-called DRAMs. So I really wanted to emphasize that point because I see the lot with facilities. You have high viral loads for 2 years. Somebody 2 years, if the viral load is high, coming to the facility, no one is switching the treatment. Yeah. So really, drug resistance is really about mutations that will occur, and that mutation will cause the drug either not to sit in that site or not to act or whatever are active sites. So there's a change in the conformation of the target site. And really, if you remember your amino acids, they'll have a position where there will be an amino acid, a peptide chain. There will be a position where there will be an amino acid, and that will change. So really, there's this famous mutation, like the so-called, a good example usually use the terms of the nomenclature, the M184V. It simply means that in the wild type, there was an M, and in this case would be like methionine as an amino acid. Then there will be a change to valine, which is another amino acid, at position 148. And depending on which position there's a change, the results will be different. But most the ones that will really cause drug resistance are known. And this is just what to say what happens in terms of the codons. There will be a change in methionine because the methionine changes, that will change in the peptide and the like. So really, there are mutations that are major. They will change susceptibility. And there are those minor which will need other issues like secondary or accessory. Then there are naturally occurring mutations. Some of these are not naturally per se. They will be elicited, but they will not have consequences in terms of drug susceptibility, the so-called polymorphisms. So, but it's the major ones that commonly will result because of drug pressure that will cause drug-resistant mutation. And because of that, you find that there will be change in the susceptibility of that drug. Sometimes there are drugs where the dosages will work at a higher dose when there's that. For a good example is DTG itself and darunavir, where we know that some people with pre-existing resistance, the dose is much higher. So there's this relationship without changes, the mutation and the IC50, the minimum dose that you need to inhibit that viral replication. Yeah, so you need a lot of virus. As you would remember, the issue is that attachment between the drug and the active site. For instance, if you look at NRTIs, which work on the reverse nucleoside inhibitor at the active site, for this to bind at the active site, you know that the theory of the properties of matter as they move, you might need a higher dose to have more chances of binding. Yeah. And obviously, this really just talks about the same. So there are several methods that you can know whether that mutation will cause drug resistance or it wants clinical studies, others are studies in human beings and so on. But all this is compiled to have this nomenclature that we use. For instance, after a lot of studies, we know that the M184 will arise because of lamivudine or mitristabine, and it will affect that particular drug. So that was just to talk about what HIV drug resistance is from, and sorry to attempt to get a bit deeper in the science. But let's talk about how big is the problem for of HIV drug resistance in our program in Zambia. We know that WHO does advise countries to do some surveillance, to measure HIV drug resistance, and have these guidelines, the public health response to treatment of HIV drug resistance, and what drugs you can use. Typically, we know that for NRTIs and a lot of other drugs, once the prevalence is above 10%, that drug might not be reasonable that you use it in the public health program. So we do measure our HIV drug resistance prevalence or problem in 3 ways: the country as a program. We have these periodic surveys, and then we have now routine HIV drug resistance testing for all treatment failures, especially those who are of INSTIs and PIs. So this is crucial. Everybody who has a high viral load after EAC should have that testing for surveillance reasons and also for treatment reasons. Then we have these routine surveillance studies, a study that has interest in people in several sites. Like right now, we are running what is called the CADRE study, I think being spearheaded by UTH. And it's in all provinces. We are picking these samples of people who are failure to analyze and see what's happening in terms of HIV resistance. Yeah. So these are the main ways, and obviously there are other small studies. Chiefly, these are the ways that we're trying to assess the problem as an industry. So we did have a survey in 2019 to 2020, and pretty much I'll not go through in most of these data, but we did this in children and in adults. So we're looking at pre-existing drug resistance, the PDR, and acquired drug resistance at 12 months of therapy, those who fell after a year, and also 48 months, which is about close to 4 years of treatment. And then for children, we were trying to get acquired drug resistance at 12 months and also at 36 months, which is 3 years. You can see that we couldn't do HIV drug resistance for children pre-existing because there are very few children who are starting treatment. So these are the number of patients we sampled and so on. Those were enrolled, as you can see. So this was a good study. You can see that the sample was really good. Total sample was close to 2,000 patients that we got to test this. So these are the results. This is just the demographics and the characteristics. You can see that this is the number of patients who are really typical for adults of our cohorts. You can see that mostly were females, as you would expect in the program, and most of them were above the age of 25, and what we expected before. And a number of them were on first line, and there were a few who were on second line, but a number of patients were on DTG-based regimen, you can see, especially for those who are contributing at 12 months and 48 months. So that is to note. And most of the subtype HIV was type C. I think this might not be very important, but we know that it represents our patients. For children, most of them were on first line, just a few on DTG-based regimen. Reason being at that time, our surveillance, our DTG was really rolled out fully. So the take-home message is really that efavirenz and nevirapine was at 16%. You can see here, this is pre-existing HIV drug resistance. A lot of patients were suppressed, as you would expect. Even in children, suppression rate was very high. More suppression rate was for those on DTG with an odds ratio of 6. In terms of acquired drug resistance, you can see that there was substantial acquired drug resistance to most of our drugs. No drug resistance to PIs, and East is at that point in 2 years ago. That's in 2020, and 2019 and 2020. But you can see that Abacava, efavirenz, neferapine, those who are failing, there's over 70% likelihood that resistance, and over 50% chance for those that are TDF, and this is in keeping with even other studies elsewhere. Yeah, for children, again, it was similar. There was, for those who are failing, there was quite a lot of HIV resistance found. Yeah. I'll quickly, so we know that over 16% of those people who are starting treatment, they have resistance to NNRTIs, and those who fail treatment, well, over 70% will have resistance to NRTIs and Abacava, and over 50% to TDF. About 60% or so to AZT. Yeah, so what do we do in terms of those who have treatment failure, in terms of routine HIV drug resistance testing? That was a survey that we presented. Now to the second, where we are measuring HIV drug resistance. So we are saying all confirmed HIV virological treatment failure cases on ART must have a genotype HIV drug resistance test done after enhanced athletics counts. So please remember this. And there are 3 types of treatment failure. We know what these are, and we know a definition for treatment failure is for more than copies at 1,000. 2 of them after ESC we take for HIV drug resistance. And we know why patients actually fail. And we know that those who have very high viral loads, usually it's not that they're taking their drugs and may not have resistance, they say. Yeah. So this is very important. It's in the guidelines. Everybody who fails first line, after ESC repeated test, after that, you switch, you don't wait, but you collect blood for genotype. We can have the second question.
Yes, sure, Dr. Seville. I think we'll go to the second question. Just launching it just now. All right. Okay, so yeah, so our second question reads, when is it best to collect the HIV drug-resistant tests? When is it best to collect the HIV drug-resistant tests? So option A, just at the beginning of taking ART. Option B, when the patient is non-compliant to ART and the viral load is over 1,000. Option C, when the viral load is less than 1,000. Last option, option D, is when the patient has proof of taking ART, but the viral load is greater than 1,000. So very, very interesting question. Let's all give it a go. So give it a few more seconds for everyone to take part. So which one is the best timing for doing HIV drug resistant tests? I think that's what the question is asking. All right, so we have over 50% response, and I think we're going to end the poll at this point. Yes, so the majority have actually gone for the last option. That, you collect the best time to collect the drug resistant test is when the patient has proof of taking ART, but the viral load is over 1,000. Thank you for all who's participated. So Dr. Seville, those are the responses, and the majority have gone for option D. You can comment and proceed with the presentation.
Yeah, thanks, Kenneth. So we do not encourage taking HIV drug resistant tests at the beginning of taking ART. So usually you just pick that wild type. Remember the green? That's what you amplify and it will not be useful. Yeah. When the patient is non-compliant, they're not taking ARVs, you're not so sure that they're taking, again, that green will multiply. That's what you pick. So typically for the test to be able to pick, virions that are resistant, you need those resistance virions to be at least 20% of the population. So if most of the virions are non-resistant, there is wild type because somebody isn't taking ART, the results will not be good enough. It will just show the wild type in the actual group of resistance. When the viral load is below 1,000, typically there will be very little virus to collect any, to amplify, so the test will not work. There are a few good tests, what is called like a GenoSure, which will pick a bit, but we don't use that in the country. So the best time is really when somebody is taking the ARVs. Here, you expect that those susceptible populations, the wild type, will be cleared by the backtracks, and the ones that will be dominant will be the ones that are not susceptible to the drug. So that's the time. So this is very, very crucial information. So from this diagram that we have, we are saying someone must go to AIC. It must be proof that they've started taking the ARVs. That's when you switch you do a genotype. You do not wait for the results. You do switch them to the results, to the therapy, but you collect the genotype test. So this is what we recommend, and very, very crucial. So we can have the next report.
Right, thank you, Dr. Seville. So go right ahead and do our third poll. I believe should be the last one. Okay, so, all right, so poll question 3 reads, when is it best?
This is the same one.
Oh, sorry, this is the same one. Apologies. I think it's moment to launch the other poll. Dr. Seville, we can't seem to see the other poll question. Maybe we can go right ahead, then I think we'll... Yes.
What we are saying is only collect the genotypes the patients who have completed AC and still have a high value. Do not wait for the results before you switch to second line. Only central labs will have the capacity to process the genotype, and sample transportation costs must be attended to as to my second line after genotype results, genotype testing will, with help with HIV drug, will prevent unwarranted progression to salvage therapies like third line. So,
yeah. Dr. Seville, we can't get you. You are too faint.
I'm too faint? Oh.
Yeah, maybe, yeah.
Better now? Is it better now?
Well,
is it better? Better?
Better now. Better now.
Okay. Okay. The machine was a bit far from me. Okay. So management of treatment failure once you collect these, and how do you deal? So I also want to emphasize that patients who have high viral loads have got a risk for progression of the disease. we are still seeing quite some mortalities in the program, and this is that delay. Like I mentioned, we continue seeing about the need to act quickly. And barriers must be evaluated why somebody is not taking drugs and corrected before therapy is changed. Let's look for those opportunistic infection before we change therapy. Iris and so on. Sometimes it's really like putting fuel, or is it fire on fuel, or vice versa. I must also say that the high viral loads, despite that it risks the progression, risks the development of HIV resistance itself, but there's also a general risk of transmission, HIV transmission through sexual partners. So this is why we know, this is why we switch therapy, and these are our drugs. Not that we do recommend the darunavir here for adolescents and adults, and adolescents above 12 years old. Where it's available, we recommend it, and now we are recommending that all adolescents that are on PIs, let's say AZT50C and lopinavir, should be moved to darunavir, as the guidelines do already say, the 2020 guidelines. So for co-infection, these are things we have discussed several times. Not that those who switch, if they are on lopinavir, or they are on atazanavir, or they are on darunavir, and they are on TB treatment, if you don't change drugs, or you don't, that is, increase the LPV dose, you are pretty much just cooking HIV drug resistance. That's what we meant when the dosages are not correct, or you're using the wrong drugs. You are cooking protease inhibitor resistance. So I think this is very important. Ensure that the viral loads, before you even recollect the viral, somebody should be taking treatments. So, and this is our referral system. A lot of issues have been said over this. So what we are saying is, we have these referral labs, the 4 HIV drug resistance labs. There are 4 now: UTH, ADC, HIV, UTH virology labs, and CHARS labs. So all facilities, they will refer first to their level 2, or which is in this case the molecular lab, where you send the genotypes, your viral loads, and it's that lab which you send to the ATC lab, or these genotype labs. Obviously, you have to put the the requisition and so on, which will be visible to us. So the requisition form for HIV viral load now has got a section for HIV drug resistance. Please fill that part. Crucial information that is there. We want to know the drug someone is taking, how long the vulnerability. I wish I had put a sample in this presentation, but if you don't have the correct one in the facility, please get the correct one. Otherwise, that visibility you see here at MOH will not have it in the system. But what I want to say is, the results will be sent back to the referral lab, and it's at that point that the facility will be formed. You can see in terms of the communication. So the results, usually not SMSs here, maybe just that the results is available, but you have a DISA system, which I will mention. So again, the question is, before I even move on, the other issue is the requirements to process the lab and transport it. So a number of samples that we are getting, and I'll pick the far-flung provinces like Chinga. it's advisable that you can transport liquid nitrogen, but if you are nearby, even ice, you can do that. But you find that the sample spends maybe a day or two. The driver starts off in the morning. They reach Lusaka in the evening, they sleep with the sample, it's just in ice. You find that by the time you try to amplify it, it's not viable anymore. So we do have liquid nitrogen, which we send for this purpose at MSL, for it's a far from provinces to help transport these samples. So that is one of the crucial gaps that we've noted as a problem. Accessing HIV drug resistance results, because the results come as a page, you can't really SMS them or just read them and so on. So currently they are being sent as an email to the provincial focal point person at the provincial molecular labs. So I know there hasn't been, they haven't been that responsive, but we are trying to establish a portal at www.diza.com, which people can log in, put the patient details, and find those results. But as you expect, access will be restricted for obvious reasons of confidentiality. Interpretation of results, we still maintain that we do not rush to interpret the results. Allow trained, skilled people, because sometimes, like I've said, if the sample wasn't collected properly, there will be what is called archiving, where you will not be able to see the mutations, but everything in the clinical story suggests that there is mutation. Sometimes drug history is incomplete and so on. Yeah, so these are some of the issues that a patient history exposure is critical before the decisions are made. So consult with specialists, and we are trying to put specialists at local level to decentralize the whole system. Copper Belt has specialists who can do this, and they do give the service to Northwestern, Eastern Province as a specialist. Yeah, and we do support Central Province. There are specialists in Southern Province to do this kind of a thing, and soon we have somebody for Western Province as well. Yeah, so this is what we advise to be done. Lastly, just want to say that we do have evidence now that from Malawi that DTG resistance does occur. That's why we are saying let's prioritize all failures to DTG should have a genotype test. Yeah, and also important to show here that this is in the Nadia trial. They did find some DTG resistance and no darunavir resistance. And that's why we are trying to ramp up the uptake for darunavir as a program, because seemingly it's got a higher genetic barrier to DTG. So this is the summary of my presentation. We recommend routine HIV drug resistance for all patients. The news now is, as of last week, we've started doing insti resistance in the country. We are able now to tell you about resistance to darunavir, to dolutegravir. There's been some problems with technical issues, how to do that, but now there's some technical support we received that is working on. All our labs have reagents, the 4 of them, and they are functioning as I speak. Yeah. I'll end here.
All right. Thank you very much, Dr. Savile, for this wonderful presentation, very comprehensive. Yeah, so at this point in time, I'll give this opportunity to the network to, I'm sure we have quite a number of questions, clarifications, and comments. So this is an opportunity for the network to give those comments or questions. So those who have questions, you can kindly raise your hand, then we'll be able to support you. You can also put your questions in the chat box. Yeah, so there's one question in the chat from Dr. Irene Boalia. think Dr. Alinwar is trying to ask why recruit more children when we have a smaller number of children on treatment compared to adults. I believe, Dr. Wale, is it pertaining to one of the studies that was shared in the presentation? Maybe if you could unmute and maybe ask a question, give it a bit more clarity. Are you referring to the study that was shared in the presentation?
Thank you very much. So yes, I was referring to the study when we were going through the study design, looking for HIV drug resistance survey. So I noticed that there was slightly more children enrolled for that study compared to adults. Thank you.
Oh, thank you very much for that clarification, Dr. Valia. So we're still inviting some more questions and comments from the network. I can see we have colleagues joining us from far and wide. I can see Mungwi on the call, also Western Province. So let's kindly ask our questions. We have experts to help us answer some of the questions that we've been having in the facility. So let's kindly answer or raise our questions and comments. I can see Dr. Chitembo Laston, your hand is raised. You can kindly unmute and give your comment or question.
Okay, just as an addition to what Dr. Sevili has presented, thank you very much, but I would also want him to come back. Primarily, there are two key issues whenever we are talking about HIV drug resistance. There are what we call patient factors, as well as programmatic and clinic factors. So he has done a good job regarding the patient factors, but there are also programmatic and clinic factors, which include the prescribing practices, the loss to follow-up, retention on ART, on-time pickup, on-time clinic appointments, drug supply continuity, issues of adherence, and viral suppression. Those are the programmatic and clinic. So Dr. Seville, probably it would be nice if you could talk about what we call the early warning indicators. I think these are crucial. Over to you, Seville.
So thank you very much, Dr. Chitembo. Dr. Seville, we have those two questions. The first one is pertaining to the survey. Why did we have more children compared to adults? Then also, Dr. Chitembo wanted you to elucidate more on the other factors other than the clinical factors. Well, what are the warning signs for drug resistance? Over to you, Dr. Seville.
Yeah, so the issue of the number of children, the slides, it was an issue of power. Yeah, so this is the protocol was WHO's specific, it's an international protocol, and the statistical, the statistical calculation of the population was prescribed, but I think we were looking at power because it's assumed that HIV drug resistance is slightly rare in children than in adults, so you needed slightly more numbers of children to recruit. Yeah, because so to have power, so it is a statistical calculation. Yeah, so Dr. Chitembo, just to thank you for bringing those up. Yeah, so we do have, and I must say maybe we're doing slightly better in our program, but we have to watch some of these things that are early warning indicators for HIV drug resistance. Like mentioned, viral suppression. Right now, and again, I didn't want to really talk about that because our viral suppression seemingly is high. 2 weeks ago, I was at Kafue District Hospital, going through the records, it's 99% viral suppression. So, but there are those patients who are unsuppressed. That's why I try to emphasize on these patients we have on EAC in our registers. I think those, as we monitor that, that's where these early warning signs will become visible. questions, why are they taking so long? First, why are they even unsuppressed? Why are they taking so long before they suppress again? You know, so they'll speak to our program. I think if there's anything I would like to remind us is we need to be quick to optimize therapy, find these patients, counsel them in ESC, do the ESC process correctly. Then we don't have big warning signs right now in the program, but that will prevent us from going there. So really the warning signs are the same. Viral suppression rate, what is happening, close to fallout, patients that are non-adherent, the ESC issues, and of course also how often, how quickly you change. So that Malawi study I showed, it was case reports. So the 8 patients that were actually had DTG resistance, they were found to be patients who were viremic for a very long period of time, over a year, you know. And again, these are patients that we see, you know, I don't know where this instruction is coming from in the program that after ESC, someone comes back, if the viral load is still high, continue ESC again. No, the instruction is clear. After ESC, viral load is still high, switch the patient. Switch the patient. So you have those early warning indicators. You keep the patient longer on a high viremic failing regimen, you are just cooking resistance. I thought I re-emphasize on that. And thank you for bringing this up, Dr. Chitembo.
Thank you very much, Dr. Seville. Yeah, so we don't seem to have any other questions, but feel free to raise your hand so that you comment or give the question. So as people are still thinking of questions or in comments, I think I'll afford this time to our experts to give a comment over the topic that was discussed. So joining us is Dr. Chitembo, who's already, of course, given a comment. Dr. Chitembo, welcome. You're one of our experts today. I'm also joined in the hub by Panji, who will introduce himself and give a few comments. I think our other experts are yet to join. So Dr. Chitembo, any comments, any word pertaining to the topic at hand? Over to you, Dr. Chitembo.
I think for me, the early warning indicators, as explained by Dr. Seville, is something that we must make sure that we implement and we keep an eye on, because that's what's gonna help us avoid HIV drug resistance or make us succeed. In other words, get every patient virus suppressed. Thank you very much.
Thank you very much, Dr. Chitembo. I'll give this opportunity to Mpanji to give a word or two. He will introduce himself and give us his comment pertaining to the topic. Mpanji, you can go ahead.
Thank you very much. So my name is Mpanji Siwingwa. I'm from Adult Center of Excellence Laboratory here at UTH. Thank you very much, Dr. Seville, for highlighting quite a number of interesting things there. But maybe just an emphasis that I wanted maybe to bring out, just a few things. I know Dr. Seville mentioned, but the issue to do with the integrase assay or test that we're offering for HIV drug resistance testing. I know it's something that we started running last week, so please would encourage people to request for patients that require HIV drug resistance. Specifically, you can send them at UTH, Adult Center of Excellence Laboratory, or you can send it to the pediatric site at the Pediatrics Center of Excellence Laboratory, or on the Copper Belt, you can send it to Arthur Davidson's hospital. There's a laboratory there for HIV drug resistance testing. So whichever is easier for you to refer a sample there, please feel free to do that. Then the other thing I also wanted to make mention of, which just an emphasis, which Dr. Sivile mentioned, also has to do with the cadre. Others would call it a cadre study. It's in all the 10 provinces in Zambia. There are some facilities that we have selected from each province. So if you are from that particular facility, please do make sure that you fill up the form as Dr. Sevilla mentioned, and make sure that all the samples that you are sending there, they have completed the EAC testing. So what's happening is that in that lab-based surveillance study, all the participants that qualify for HIV drug resistance testing, they have to make sure that they complete the EAC sessions, and also that at the last viral that they do post-EAC has to be above at least 1,000 copies. So there's this surveillance that we are doing, and we are compiling data for, so every year we would compile data and we'll send to MOH for them just to at least look at the patterns and what sort of mutations that we are having for that particular study. But then also what is also interesting for this study is that we are doing both the usual genotype that we are doing as well as the integrase panel. So we'd encourage those who are part of this surveillance to follow what we have explained to all the facilities and make sure that you send the samples with the right conditions that Dr. Philip mentioned, and then the results will be sent back to the facility. Then lastly, the other thing that I wanted to make mention of, I know that we've been having challenges with results being sent to a facility. So what we are trying to do as a lab is to see how best we can improve that particular situation. So we are trying to come up with modalities or ways of how we can improve, especially ensuring that the particular sample that comes to ETH reaches the intended facility, so that the clinician who is seeing that particular patient can attend to that patient when the results are ready. Thank you very much.
All right. Thank you very much, Panji, for those comments. I guess the network has gotten the message, a number of things going on. Of course, now we have the INSTI genotype that's been done, and the CADA study. So thank you, Panji, for that. We have, I think we'll pick last two questions. Webster, your hand is up. You can quickly unmute and give your comment or question.
Thank you very much, Chair, for this opportunity. I only have two, I don't know if it's questions or comments. I know we have done so well in terms of the suppression, but when we look at the coverage in terms of the viral load, I think we are still not doing very well, and that's why you find that most of them may still have very high viral load, because you find that maybe a facility has only coverage of 60%, of which 90% are well suppressed. It means that we still have 40% whom we don't know the status. So I just wanted to know what you are doing from the top, from the national level, in order for us to improve the coverage in terms of the viral load. And then I also wanted to find out what is the current turnaround time for the genotype when you send the samples, because we can't manage what to send the samples to Lusaka. So what is the turnaround time for different provinces? I submit.
Thank you very much, Webster. Those are very, very important questions. Thank you very much, Webster. So, so these will be our last question. So, question in the chat box as well. Yeah, so I'll go through the questions, then I'll allow our experts to give a response. So the first question from Webster is regards the viral load coverage. In as much as we are recording good levels of suppression, but the viral load coverage has been isn't so great. So the question is, what are we doing at national level to improve viral load coverage? And the second question from Webster is, what's the turnaround time for genotype results? Then Panda Moses in the chat asked a question also pertaining to turnaround time, but I think this pertains the viral load. So what's the turnaround time for I believe this should be viral loads. How long does it take for drug resistance? I don't know whether this pertains to viral load and drug resistance. Probably we can tackle both. What's the turnaround time for viral load and what's the turnaround time for drug resistant? That is a genotype. Dr. Seville, I will allow you to take the first question, and probably Panji can help us with the lab. So Dr. Seville website is asking about what's being done to increase the viral load coverage at national level. Over to you, Dr. Seville.
Yeah, thank you. And Dr. Webster, where you are from Copper Belt. So we are disappointed as a program with Copper Belt that you have a low viral load coverage. And the question is not a national issue. It is a local issue. You have so many labs for HIV drug resistance, including the one at TDRC that is never used. Samples are going there, but reagents are there. So in terms of our capacity to do HIV drug viral load, we have more than enough capacity in the country. Like I've said, there are even machines that are not receiving samples over there in the Copper Belt. The issue is really at demand creation, facility level, calling patients. In these provinces like Eastern, Southern, we did that where you go through the facility list, the treatment cards, and see those who don't have a viral load, you call them. So a so-called like a viral load surge or a campaign. So those are some of the things we are promoting. It has worked very well in these other provinces. We advise that Copper Belt, Central, these provinces which are not doing too well, Northwestern, they do that as well. So I think it's a practice that we can learn from Southern, Eastern, Western provinces, which have done this. That's what we recommend. But again, I think the province needs to organize itself in Copper Belts because the capacity is more abstract. Even the HIV drug resistance labs at ADH, the problem that they have is samples and requests. Samples are not being taken, requests are not being done for these patients. And that's my answer. Panji.
Thank you very much, Dr. Seville. Panji can tackle the turnaround time for viral load as well as the genotype. Just briefly.
I think that one is for virology lab, right? Okay. Okay. Yeah. Thank you very much for that. So, two comments regarding the turnaround time for HIV drug resistance testing. So, as things stand, like Dr. Seville had mentioned, we just resumed testing for HIV drug resistance last week because the last 2 months or so we were validating the kits that we use for HIV drug resistance. So we have accumulated the backlog and things like that. So as things stand right now, so we are at 6 weeks. It will take you about 6 weeks for you to receive a result for HIV drug resistance. But our goal beginning next year, second quarter of next year, is to reduce the turnaround time to 2 weeks. But currently, the turnaround time should take you about 6 weeks for you to get your genotype results ready. And the reason why it's gone to 6 weeks is because of the backlog that we had. We had some interruptions of supplies at some point. So we accumulated a backlog. So we're trying to get rid of a backlog. So we're hoping that next year, March, thereabout, we can now start doing the HIV drug resistance within 2 weeks. Thank you.
All right, thank you very much, Panji, for that response. All right, I think we've exhausted our allocated slot. Thank you very much. Just a quick comment from Dr. Seville. Any last comments in just under a few seconds?
Yeah, for me, it's just to encourage people to bring the samples for this. those who are failing second line are a priority. That's why I want you to fill in that form so that we can pick them in the labs, work on them quickly. Children are another priority for this HIV drug resistance. So those, the turnaround might start quicker. If you need the results quickly, give us a call, reach out to us. We are always open. There are some facilities that are doing that, and we thank you for taking that initiative. Some of you have given the results in as quickly as 3 weeks. Thank you.
All right, thank you very much. I think we've come to the end of our session. Thank you all. Thank you everyone for joining us for this quite important topic. Special thanks to everyone from the network. We value your participation, as we believe this will help in the patient care back in our facilities. Special thanks to our didactic presenter, Dr. Seville, for that wonderful presentation. And we also want to thank our experts who came through this afternoon. So thank you all. We'll meet in 2 weeks' time with yet another interesting topic. Thank you very much. Have a good afternoon.